You can start recording. Yeah. Welcome to the September installment of Probing the Literature, ACEP and SAEM Ultrasound Section Journal Club. For those of you who are new to our game, what we're going to do, and this is going to be in Eastern time right now, but what we're going to do is we'll start with a speaker introduction. Dr. Rob Ehrman will talk to us about an article related to sepsis and ultrasound, but I think more broadly, kind of putting all of this in perspective. And then we'll break out for some small groups for about 20 minutes, discuss the paper, which is going to be on hyperdynamic function in ultrasound and sepsis and septic shock. And then for the last 5 or 10 minutes, we'll meet back, kind of talk about our learnings, design new studies, and fix this problem once and for all. After that, for about an hour, we have kind of an open forum where we can talk about any studies that anyone has, any methods questions, any big burning things that people want to bring to a discussion. So we'll start with the discussion of the article, "The septic patients with reduced LV ejection fraction require a low volume resuscitative strategy." Dr. Rob Ehrman is our guest speaker today. He's an associate professor at Detroit Medical Center, Wayne State University, and completed his emergency medicine residency at Yale New Haven Hospital, ultrasound fellowship at Cook County Hospital in Chicago. In 2019, he developed an interest in biostatistics and research design, completed a Master of Science at the University of Michigan. He is Director of Emergency Ultrasound Research at DMC, member of a Biostats Epidemiology and Research Design Group at Wayne State University, editor, Methods and Statistics editor at Academic Emergency Medicine. His research focuses on the use of heart and lung ultrasound, combination with biomarkers to optimize fluid resuscitation and sepsis. He's received research funding as PI from NIGMS, SAEM Foundation, and multiple industry contracts, collaborated on multiple studies involving echocardiography and lung ultrasound in acute heart failure, funded by NHLBI, NIMHD, which one is that? And EMF.
Minority health and
yeah. So I'll let you kind of just start talking. I'm gonna stop sharing and we'll try to kind of focus in on you. And I was hoping you could tell us kind of about this topic from your perspective. I'll say, this is something I've been interested in since I was a resident, and probably a big reason that I went into ultrasound fellowship, because I felt like this was such an interesting topic and such an easy thing to teach people. And the more I dug into it, the more it felt very messy. So I'm curious kind of how you approach this.
Yeah, totally. I could talk about this ad infinitum. So when you want me to stop talking, just say stop talking or send me a message in the chat. Yeah, thanks for having me. Hi, everyone. So yeah, I mean, I think it's like an interesting topic too, obviously. And I sort of, I don't know, I got interested in it sort of like in residency as I worked on like a chart review study in sepsis. And then, everybody like loves to talk about how, we don't like the sort of blanket recommendation of 30 cc's per kilo. We know it's, it's too much for some people, and it's, too much is bad, not enough is bad. Like, how do you find the right answer? And so it sort of seemed like echo was sort of the I don't know, the ideal way to do it. I think when I was a resident and then like a fellow, now almost like 10 years ago, but that was sort of like the heyday of like the IVC, like, is it fat or flat? Was it, fluid responsive? Then it became fluid tolerant. And that's, a little bit of like an incomplete picture, I guess. Right. And then, so I thought, just looking at the heart would be the answer. And, exactly like you said, it's extremely messy. Some of the things that as I learned more about echo, became apparent, the really big ones are that most measures of cardiac function are load dependent, which means that, preload preload and afterload are going to affect them. So this, goes for like EF, even like longitudinal strain is load dependent. And so, in the setting of sepsis, that becomes relevant because, just we're talking about EF, so we'll stay on that topic, but EF can change, right? So it can change, depending on how we treat the patient. It can change depending on some of the sort of inherent state of the patient as they move through their illness. Obviously, like vasopressors can affect it. And so if you, look at some of the original literature, like echo and sepsis, the biggest glaring thing to me was most of these studies were done in the ICU. So the patient is, 6, 8, 12 hours. Sometimes, echo is reported out to like 72 hours after they're admitted to the ICU, and saying like, look at these associations or not between EF and outcomes. And it's like, well, the horse is out of the barn at that point, because, in the olden days of sepsis research, right? Like these patients would get like 6, 8, 10, 12 liters in the first, 12 or 24 hours. I mean, I definitely remember when I was a resident, which was 10 years ago, like patients would be in the ED and boarding was an issue, but like easily you could give a patient 6 or 7 liters. And that was like, oh, they're still kind of hypotensive. Should we like work on 8 and 9, or should we maybe like put in a central line and start pressors? So, to me, that's kind of how, like, that is like an enormous confounder. And so that's kind of how I got interested in doing this work, which was, looking at EF, looking at measures of cardiac performance when patients sort of hit the door. And, again, the other one big thing that's always a challenge, and I don't know if there's like a way to address this problem, is like, what is the what is like the pre-septic cardiac function, which is, probably unknowable, in the sense of like, some people have, like in this study, I think, like, if I can't remember, like some proportion had an echo within the last couple of years, or a couple months, but it ranges anywhere from, you might get lucky and have somebody like a month ago, but maybe they had an echo 3 years ago. And so obviously if somebody had an EF of 50% on January 1st and then becomes septic on January 31st, and now their EF is 30%, that probably means something different from somebody whose EF was 30% on January 1st and now is still 30%, versus someone who was, say, 15% and is now 30%. So it just, there's so many like moving parts that it becomes difficult. I don't want to say impossible to study, but extremely challenging, and then finally, I guess, the last thing I would sort of say is, it is the heart's kind of the center of the circulatory system, but it doesn't exist in a vacuum. And there's obviously connections between the heart, the lungs, the central venous compartment, the kidneys. I'm sort of, you can see where I'm going with this, sort of like the Vexus approach. There's a lot of, I think, it makes sort of like empiric sense that looking at multi-organ ultrasound would be useful, because, whatever happens to the heart, or whatever, you do to the heart is going to have upstream and downstream effects. But as it pertains to some of my, current research, ultrasound is informative, but probably not enough by itself. Just as, an example, if you think about just sort of the renal component of Vexus, where you have these changes, phasic change, or changes in phasicity of blood flow, that, that's happening at kind of like the macroscopic level. At the microscopic level, you start to wonder, I mean, there's all these different changes in the endothelium, what's getting, secreted, you're changing, your GFR, but a lot of other stuff is happening. And so, it's sort of a, on the one level, looking at just, ultrasound is a start, but I think it's probably not the complete picture, sort of in the same way that just like thinking about IVC is like fat, flat, or kind of in between is probably not the whole story. If that kind of makes sense. Yeah, that's kind of the introduction. Do you have questions I can
Yeah, I think so. I think maybe to peel it back a little bit, I'll kind of introduce how a lot of us think about this, right? This is a pretty ultrasound friendly group, right? And so I think everyone has their approach to say, okay, this person needs 30 per kilo, this person doesn't, this person I don't know. And as ultrasound people, I think most of our teaching is around like, for those people that you don't know, put a probe on and see what their preload compartment is doing, see what their lungs are doing, and see what their EF is doing. But what we don't know is like which of those components actually means something to that person in front of you and what's reliable to make that change. I think one of the things that you mentioned is, hey, like you have to, in order to understand what it means in that moment, for most of us, that's like the patient hits the door, right? You have to do the echo early. And so that, in my mind, raises a lot of logistical challenges. And you've done like an amazing job of capturing these people, albeit as a convenience sample. What kinds of, like in your study design to put this together, how did you approach those challenges and get that protocol in place so that you could at least start getting at that question of like, what the hell is happening early on? Because that's a kind of a set of study challenges, and maybe that'll be something that's kind of interesting. Because I think for a lot of our fellows, people want to understand these kinds of stuff, and getting a protocol like that set up is an extraordinary amount of work for a 1-year fellowship, even if the previous fellow started it and things like that.
Yeah, 100%. I mean, there's a lot. You made a lot of great points in there. So I'll try to hit what I think are the kind of most important ones, the ones I can speak most to. I mean, one, yes, I think like getting it, to me, getting the echo as soon as possible when they hit the door before you've started doing anything to them is like is really critical, because you just that baseline is really not available anywhere. Not to say that like I'm so that I'm so great, but like I think that's like a novelty of the study that we did. It is like extremely, it was extremely difficult, and like it was like almost bordering on the level of miserable. This is like a challenge in point of care ultrasound research, is just like trying to find the balance between like working a clinical shift and enrolling a patient versus like coming in on your like off time to enroll a patient. Which when you're doing one, the other one's like, I'm going to do it this way. And then when you're, doing the other way, you're like, this is terrible. Like from a pragmatic standpoint, like saying like, hey, this is what I'm going to do, was, relatively straightforward. There was some, from a study standpoint, we had to make the case that echo is essentially standard of care in resuscitation. And because the idea was that we could obtain the first images without consent, which is like key, especially in like the sickest patients. That wasn't like that heavy a lift. Most, it's pretty well established. I mean, and so whenever I did this, this started like, I don't know, 5 or 6 years ago. But now it's like much more evident that there's all kinds of society guidelines that just say that's what you should do. And so that was, but that was part of it. But I think, we did the study for, I don't know, 2 years, 2.5 years, and I think we got images on just over 100 patients, and then a lot of them we couldn't get consent or they died or this and that. So, and we're actually trying to do like repeated measures. They got 0, 3, and 24 hours, which was just like torture. So it's, it's like sweat equity, or it's a labor of love. I mean, it has to be that. It's kind of the only way to do it. the flip side too, like being realistic, like you said, doing it within a year is like, I mean, honestly, like part of me never wants to do a point of care research echo ever again in my entire life. I worked on another project with another faculty member, Mark Favot, some heart failure stuff, and then someone else. And it's just like, I'm like, I don't want to do it. It's like my current study, I'm paying a sonographer a lot of money, to come in and do the studies. And there's like this trade-off between like how, they're not there. It's not going to be quite as fast, but some of it is just striking that balance between like feasibility and like long-term sustainability, that kind of thing. It's hard. I think to me that's part of why, I mean, it's not unique to my work. It's just the challenge of point of care ultrasound, because it sounds really easy. I'm going to scan these patients and we're going to do it while I'm working a shift. But like even, we tried to do like a small RCT looking at like needle aspiration versus IND of abscesses. And that should be like, a slam dunk, so easy. And it's just like, we just couldn't get it. We just couldn't do it. It was like too hard to keep it moving forward. And that's like, frustrating for sure. I mean, for fellows, the landscape is maybe a little bit different, because depending on how your fellowship is set up, you have some, you have scanning shifts, you have teaching shifts. So, like in a perfect world, you can, while you're scanning, either independently or you're doing your like teaching stuff, you might, find a study patient and be able to enroll them. But even that takes somebody that's, super dedicated and really wants to, has an interest in research. And I 100% recognize that that's the subset of people that want to do that is small. And like, 5 years ago, I was like endlessly frustrated. Mike could probably like speak to that. I used to like flog people and, verbally abuse them in, like a non super threatening way. But it's just like, it's like, I get it. Like, if this isn't your like passion, like, it's not, and that's okay. Yeah, it's very hard. It's very hard. I wish I had an easy, like an easy solution, or say, hey, just do this. But I don't.
Yeah, no, I think that's it's like a doom and gloom, but I think a fairly honest answer about like how do you get this all set up, and it is a boatload of work. I think one of the things about that, right, and maybe one of the things for people to think about is like these varying axes of the issues, right? Like one axis is how do you get it done in time? The other axis is like who's doing that exam, right? Because if you're doing a point of care ultrasound study and you're coming in and you're not actually point of care taking care of that patient, then like how does that affect your results and generalizability? On the flip side, if you're trying to find out like does reduced EF need less fluid, you can't have the person doing the echo taking care of the patient and being aware of reduced EF, because like that's completely going to guide how much fluid they're going to give, right? So like all of those axes are going to be super important. And I think what I'm hearing is like designing your study in a way that is very focused in your question and really thinking about what your question is ahead of time, so that the study design that you have actually meets that, right?
Yeah, for sure. I mean, like this is one of the lessons that I've learned like painfully over the years, but yeah, like study design like is so critical. You want to have everything like ironed out and set before you start collecting data. I mean, there's always going to be little hiccups. But like exactly like you said, and you bring up a good point, which I don't know that any reviewers ever actually caught up on, but like some of the times I was doing echoes on patients that were like my own patients, and that like inevitably probably introduced a bias. But yeah, I mean, these are all the things that you're right, like they're hard about research in general, but that's just like such a critical thing is like the design phase. Talking to somebody that's like knowledgeable and can help you design the study so that you don't wind up, the worst possible thing is you collect a bunch of data and then you show it to a statistician or a methods person. And it's like, this is, unrecoverably flawed. Again, sort of challenging for fellows. Sort of on the flip side, I don't want to be all doom and gloom, because I love research. This is this is what I want to do, and or it is what I do, and I want to kind of get more people interested in it. Some of this stuff lends itself to sort of like you were saying initially, sort of like longitudinal projects where it can get passed from year to year, or you have a faculty champion or mentor or someone who's kind of running the study. And it can kind of get passed from person to person in sort of particularly as it pertains to like secondary analyses. So you kind of that goes along the lines with sort of like how you design a study and plan for it, whereas you have like your top level question that you're going to answer, but you have a bunch of like sub studies or secondary analysis that you can do. So like maybe I do the first study as a fellow with the fellowship director, and then the next year the next fellow comes in and kind of like finishes it off, and then there's a big data set in there that allows for multiple publications and projects. The timeline for research success is just like so much longer than I initially thought it was, and I think most people consider it. It's like, again, it's hard to do a fellowship. It's hard to do a 1-year fellowship and have a lot of output that year, unless like you come in and you pick up something that's like ongoing. And it can be hard to say like, all right, well, I'm going to work on this, and I know I'm not going to see a publication for 12 months, 18 months. That's why to some extent, it's incumbent upon, faculty to kind of keep that going, to kind of, drive the interest. But again, it's like, it's quite challenging. But I think, again, even doing things like this journal club, talking about all these different types of studies, is a way to sort of, pique interest, can, have people like ask questions, learn things, because it's like so daunting to start out. And that's eventually how I got interested in like methods and stats, was this just like, it's so hard to get to talk to somebody, especially when you're starting out, or people will say some stuff and you're like, you just kind of like smile and nod and be like, oh yeah, of course. Like, multi-level models. Yeah, I got it. Okay, I'll do that. And you're like, what the hell are they talking about? And I just got so frustrated with like not being able to do stuff not on my own that I just, someone's like, well, you should maybe think about like going back to school for this. And even though my wife, I thought was going to kill me, I did it. But yeah, I mean, it's, again, now I'm seeming doomy and gloomy again, but no, I mean, it's just like it's a slow, steady progress. It's okay to feel frustrated. It's okay to feel like you're not having a lot of successes early on. And it's just kind of like find the people that they're doing the kind of research you're interested in, ask them the questions. Like, I think that researchers always are looking for more people to help and collaborate with, and it's just kind of like the activation energy is pretty high, right? Like if somebody comes to me, it's like, hey, I've got an idea, I'm like, okay, cool, like do a lit search and then come talk to me again. And for 90% of the people, like I never hear from them again. But then the 1 in 20 or whatever that come and say, okay, here, yeah, here it is, let's talk about this more. Like that's when you have to like keep knocking at the door and showing you're interested, and then eventually they'll let you in.
I have a bunch of follow-up questions. I think maybe a couple of minutes talking about, I'm glad you brought up the question of secondary analyses, because both this study and the study we're going to talk about in a moment are secondary analyses. Do you have any advice both for faculty who are like planning out, what's our fellow's next project, what's the next fellow's project, how to think about secondary analysis, and how to kind of pick it up? Do you just come up with that on your own? Do you guys sit down together as a study group and say, okay, these are like the 3 next questions that I think are most interesting?
Yeah, I think it depends a little bit. Like if you're starting with something that's like was completely your own, you sort of devised the you design the study, the protocol, whatever yourself. Like a lot of it is sort of like baked in there, like especially if you start with something that's like a grant application where it's like explicitly like aim 1, aim 2, you know what I mean? Because there's all those, grant writing, it's a whole nother topic, but there's all this stuff that there's oftentimes what you really want to do, and what you think is important and what you care about. And then there's like the much more easy, more feasible, more palatable, more digestible, understandable stuff that goes into your grant application. And that's like your main paper. And then there's already some sort of like built-in stuff, secondary stuff in there. The other thing is just, is always starting with, like what you're interested in the sense of like it sounds so easy and like it even feels like kind of like, I don't know, like corny or campy to say it, but it's just like, it starts like a question on shift, like, why do I do this? Like, why, someone's like, why are you doing an ultrasound on this person who like is all volume overloaded and hypertensive and like clearly has heart failure? Like, what are you doing? And say, well, I'm doing the ultrasound for these particular reasons. And then, but anyway, so, you kind of get interested, in a question, and then you sort of find somebody that has, you do a little lit search, you find someone who maybe has a data set, and, I guess it is more challenging when it's not your own data, but, you come up with something that seems interesting. You look around, you see like who might have data, or, you look through your like your QPath database to try to, come up with something sort of like preliminary that I could say, okay, well, what can I, what can I look at is like a research question that, for example, like, and I think someone has done this, but like the idea of like, does like point of care OB ultrasound decrease length of stay? And you might say, well, I don't have it that prospectively, but I could go back into QPath and I could look at everyone that had an OB ultrasound, and I could just calculate their length of stay. And then I could, find some portion of people that had a radiology study, and I could just look at them, and I could try to, match or do something like that. That would be sort of like, I mean, I guess that's not really a secondary analysis. But it just, it doesn't have to be, it can be from, retrospective, secondary, it's just like, it starts with like a question that you're interested in, and like, what is something that's like, easy and feasible that I could start out with? Because that's what you do. You kind of start with a basic question, you do a lit review, then you see what data you might have on hand to sort of, is step one. And then you maybe start going out and looking for research funding. And it's like, hey, I'm kind of like an expert on this. I wrote a review article, on this topic. I did this retrospective study that shows some signal, and now I want to do like, I'm going to apply to EMF. I want to, like a $50,000 pilot grant to do something like this, and then, move on, that kind of thing.
Yeah. Nice. Yeah, I like that thought of like always starting with your question, and rather like before diving into your study design, be like, what else is out there, both in the literature, but what other data sets are out there that you can actually dive into? Because getting your own data, like we talked about for the first part of this, is so difficult, and it really takes resources and buy-in from a lot of different people, even if you have Mike Petrovich as your fellow. My last question, maybe in the last couple of minutes, is like, what do you think is next for this topic? Because I think, there's a wealth of ICU data, which isn't really helpful for us. There's a little bit of ED data that I think is really interesting, and is starting to dig into like who needs what from us in the ED. But it still raises a lot of questions, and it still has a lot of kind of noise in the data. What would be your kind of ideal next couple of steps, so that as a community we can address this kind of together?
Yeah, and I mean, you mean sort of like the fluid resuscitation and sepsis kind of stuff?
Totally. Yeah, I mean, for sepsis, I think we have like, there's really like three things, right? There's who needs fluids, who needs pressors, and then where's the source? That's kind of another aspect of ultrasound that becomes really helpful. But really, like, those are our three questions, and then we figure out if they need to go to the ICU because we've started an epi or not. probably have to intubate
right.
them.
Yeah, no, I mean, that's right. That's like the $1 million question, or the $1 million questions. You know, just by way of like starting in terms of like the fluid resuscitation and you know, in heart failure, the answer that I truly think right now is that we just don't know. We certainly know that too much fluid is bad, but like there's a reasonable amount of, there is a reasonable amount of literature out there that suggests that like including this paper, but like fluid restricting, whatever that means, patients with a history of heart failure, like probably doesn't benefit them at all, and may in fact lead to worse outcomes. So you know, almost anybody can tolerate a liter or two of fluids. You know, there's obviously like a huge spectrum, but like we just don't know what the answer is yet. But I would in no way would I like advocate like fluid restriction, not fluid resuscitating somebody at least with a liter or two in you know, in somebody with heart failure.
A shocky patient.
Yeah. You know, that might not be the end of your resuscitation. You may need to switch depressors, and you know, again, different question, but yeah, the data at this point, I think, you know, supports some fluid for sorry, I'd say the other way, supports that you don't need to worry about a liter or two in almost any patient, including if they have, you know, a history of heart failure. So, but it's like such a difficult question, you know, not just the heart failure question, because, you know, like something that's I think really important to think about is like sepsis is a syndrome. It's not a single entity. It's not like, you know, a broken arm or even a STEMI, although maybe that's kind of not the best example, but there are so many, the heterogeneity is so enormous. You know, you could think about like a 25-year-old professional athlete who like steps on a sea urchin in a triathlon and gets like a soft tissue infection, becomes septic, and like an 85-year-old from a nursing home with 15 medical problems becomes septic, right? We call them septic and we treat them sort of the same way, but like obviously their physiology is like completely different. Not completely different, but very different.
Yeah.
And so, you know, this is where it becomes so challenging. I mean, I think that you know, where this is going, even though I would like to say that I think more people are going to do more and more ultrasound, like point of care ultrasound, to kind of help us like answer the question. It's going to be a hard sell outside of like, you know, people like on this call to, you know, do, you know, Vexus, do repeated measures in their patients, help kind of do it on the, you know, is a routine matter. So that's why I think like some combination of, you know, ultrasound will give us some macro sense of what's happening in the central venous compartment, but really sort of looking at that's why I said like a combination of say like biomarkers with ultrasound markers, so that, you know, you can, I don't want to say like completely obviate the need to do an ultrasound at some point, but that there will be some sort of targets that can be followed without like without doing an ultrasound, without having to pick up a probe, because I think, you know, that's like a huge impediment for a lot of people still. I mean, it's changed astronomically. It's like, you know, I remember when I was a resident, and then when I started out as a fellow, I got interested in diastolic function, and I had almost never heard of you know, diastolic heart failure, which now, you know, like now HFpEF. And, you know, I was like, you know, right, like ahead of the curve, because like I, you know, could look at like E prime and, you know, E to A, and I was talking about that stuff. Now, like, you know, Mike can tell you this, like they were doing that stuff as a fellowship is like routinely. Now, like even some of the residents are like talking about it and thinking about it. So there has been a shift, but you know, I do think we're in a little bit of a, you know, a bubble,
right?
You know, so you know, something in anyways. And so there's the pragmatic there's the pragmatic side of it, but I also think that you know, biomarkers are also provide some important like microscopic, tissue level data. And just as like a quick example, and then we can wrap up. So,
Yeah.
like endothelial cells, right? Like a lot of endothelial cells are flow adapted. So what that means is they're accustomed to seeing laminar flow. And when you have, that's when like flow is parallel to the vessel wall. When you start to see stagnant flow, or you get forces that are like perpendicular, you start to get endothelial dysfunction in the short term, and then is you get endothelial dysfunction, all of these like cell adhesion molecules get released into the circulation. And so you could imagine a situation in which, as you get like more central venous hypertension, you get more of these adhesion molecules kind of spit into the circulation. And so you could pair up what the ultrasound markers look like as an idea of like, how much central venous hypertension there is. And then you could say like, okay, well, this is how much endothelial function we're seeing. And, kind of where you get to this, you kind of look for a tipping point is like, oh, well, now you're like, you've got a ton of endothelial dysfunction. Like you're going to start getting, pulmonary edema or like renal edema and stuff like that. And so, that might somewhere way down the road, like help us, decide like, okay, regardless of where you hit the door, if your, ICAM level and ECAM level are A and B, like you've already got stagnant flow. Like you really should actually get pressors right this second. Like fluid is not the right solution for you. So anyways, that's kind of like a general idea of where I think like down
Where
the
you
road.
think it's going. Interesting. I still think there's a role for ultrasound, but
No, I mean,
we'll
there
go from there.
I'm not saying there's not, there definitely is. It's just, we have to find that sweet spot between, first we got to show that it's effective and has an impact, which I think is the first step. And then we start like, beating the drum and saying like, look, you got to do this. Like, I don't care if you think it's hard, like it's going to help patients. Like,
Totally. Yeah. I think the evidence is still lacking, and we still don't know.
yeah.
Thanks, Rob. That was amazing. I am gonna transition us to the kind of old-timey article that I wanted to discuss. And I picked this one because it is one of the first, if not the first study that I'm aware of that really tried to look at that challenging thing of like getting these septic patients scanned before they're in the ICU. And I think it's one of those studies that made me think about this to begin with, and I think it's a good one to be aware of. Identifying the diagnostic accuracy of LV function for identifying sepsis among emergency department patients with non-traumatic symptomatic undifferentiated hypotension. So we'll break out into small groups and we'll go through the study and kind of think a little bit about what it means for us, combine it with everything else that we know now that we didn't know almost 20 years ago, and loop back, let's say at 55 minutes, 5 minutes before.